we'd like to welcome everybody to another in a series of our webinars. We are excited today because this one we have Dr. Falk and Dr. Lima with us. This webinar is going to be part of an ongoing series, as you know, that we're focusing on new products, clinical tools, and practical ways to assist OPOs and transplant centers to increase the number of organs that are available. This ties into the discussion we had on December 25th, in December 2025 with many of you, and also Dr. Lima's presentation at AOPA. I'd like to first introduce is Lee Keddy. He is our CEO. Many of you on this call have met him. He's been leading CompuMed in our vision and expansion of many comprehensive donor and transplant solutions to support OPOs and transplant centers. Dr. Lima, he's an associate professor of cardiac surgery at Vanderbilt University Medical. Some of you actually may have talked to him in the process of transplantation of hearts. He's now a senior clinical advisor, a member of our advisory board in helping move our vision forward. He's a nationally recognized leader in heart transplantation, mechanical circulatory support, and DCD heart transplantation. Dr. Falk, thank you, Dr. Falk, for joining us the first time. He's a founder and chief medical officer at 3DR Labs. CompuMed's been working with 3DR for quite a while, and now we've, over the last year, have been really embedding our partnership even deeper, and Dr. Falk's been a big part of that. He's based in Louisville, and he's been a radiologist for over 4 decades, so his experience is real and it's live, and he's helping us. So one administrative reminder, go ahead and put any questions you want in the Q&A, and we're going to make sure we get to as many of those as we can. So Lee, I'm going to turn it over to you.
Well, I'll just start briefly with a little bit about CompuMed. We leverage innovation technology to connect doctors and health professionals and empower impactful decisions. We also accelerate improved clinical decision-making by moving data and not people, and you'll see that theme throughout this. And this is, in essence, centered around low frequency, high acuity, high urgency telediagnostics. I want to start just briefly here, just on a couple things before Dr. Lima and Dr. Falk get involved here. But this is just a typical donor a funnel. And these are the areas that the typical OPO and transplant centers are involved in, and the areas that we can impact. And the area of outreach and referral authorization, has not been so much of our focus, but it's more been in donor management. But in some of these, you'll see how some of these novel ideas are really pushing into the potential donors and bringing those down into the funnel. So as far as the data, having the right data at the right time, there's a number of things that I just want to mention. Number one is that a lot of the data that is being collected are proxies, which really are indications of what might be. They're not of what actually is. They're excellent for determining what we have to look for, and in many cases they're used as some of the truths, but they really are indications of what might be. And they bring up questions, and these questions that the proxies raise are the reasons that transplant centers are asking for specific studies and specific, like a heart cath, etc., specific studies. And so these questions that are being raised and these specific studies that are being offered, sometimes there's other ways to get answers to that. And most of the truth of the answers to those questions is hidden in the imaging. The other thing I'd like to just mention real briefly is that donation is a low frequency event. Hospitals and transplantation is more of a higher frequency event, but organ donation itself is a low frequency event. And that is really important in the methods that we have to use to get this data out of these disparate places and get it centralized so we can make decisions on that. So a lot of the focus here is about providing answers sooner before the OR and to increase the trust in those answers. And a lot of that is in the imaging itself. So then some of the things on what transplant centers and surgeons really want to know. This is an example of the proxies that these proxies here, age, hypertension, diabetes, these sorts of things, it creates questions. And in this scenario, we're going to talk about the questions around the heart. And the question that is being raised are from these proxies. The study that is typically being asked for is the heart cath. And when we ask why, it goes into the coronaries. These are the questions that they want to answer. And these are novel way. There are novel ways to get the data around coronaries that are not through the gold standard of the heart cath. And that's really some of the things that have prompted these questions. And so in all of this, we're going to be talking about some of the questions that they really want to know that the study itself is finding, in novel ways of actually getting to that. So we started talking to Dr. Lima early on. It would have been about a year ago, and it was regarding Mosaic and our data capture. And he wanted to be involved in Mosaic. We wanted to be to work with him, and we started talking about what do you really want to know. And that's actually where one of the parameters was around the coronaries, and that's where this all started. And though we had been looking at imaging on the CT side to as an alternative to the heart cath, here Dr. Lima and his team at Vanderbilt had been doing the same thing and had numerous events, so over 100 scenarios where they were using this novel way of looking at the arteries in a different way rather than the heart cath. So without further ado, we will bring on Dr. Lima here, and he can go into his part of the presentation, and then we'll bring on Dr. Falk and have some Q&A. So Dr. Lima, if you want to.
Thank you, Lee, for the introduction, and welcome everyone who is taking time to join the webinar. I hope we'll make it worth your while. I think we will. Basically, the focus is going to be on leveraging CT scan imaging data to provide another pathway for donor heart assessment, and obviously to promote more utilization of donor hearts in the scenarios where cath may not be imminently feasible for whatever reason. Here are my disclosures. So sounds obvious, but it's important to just say out loud. You can't accept a heart without offering it first. And I think one of the themes here is that there's probably a number of donor hearts out there, maybe difficult to quantify precisely, but I want to say several donor hearts out there, many hearts that never make it to the assessment or to even being vetted by implanting centers, simply because of maybe hurdles around or barriers around getting the full cardiac or coronary anatomy workup. So this is an important theme that we hope to shed some light on. So obviously, just to go back to basics, and this is probably something that all of you are intimately familiar with already, but the guidelines officially for coronary vetting when it comes to donor hearts, at least as described in the latest iteration of the ISHLT donor heart selection guidelines published in 2022, and I helped co-author these, is really all that you're seeing there. And this is actually, just to put it in context, I think it's a 30-page document. It is a big set of guidelines. And the part that talks about the coronary vetting is this little itty bitty section, maybe 2 paragraphs. And importantly, it's a class 2B recommendation. It's not a class 1A recommendation, but it basically calls for using a coronary angiogram for quote unquote high risk donors where the concern for CAD is there. And typically these are older age donors over the age of 45 or have histories of diabetes, tobacco use, or other illicit drug use, such as cocaine, amphetamines, methamphetamines. But this is a consensus level recommendation, not proven with randomized controlled data or anything that would constitute a class, a level 1 recommendation. And I think this recommendation, this need for coronary vetting presents a barrier. maybe not as prevalent in the brain dead donor cohorts, but certainly in DCD donors, right? Where I personally can attest to several scenarios where in the process of vetting a donor heart, a prospective DCD donor heart, and because some of these high risk criteria were in play, and being told, well, we understand you would want a donor heart cath, but we can't do it. It's not possible for this donor because they're DCD. And so that in many instances, particularly early on in the DCD heart experience in this country, that led to countless declines, or just can't even pass go, where those donor hearts were not even being evaluated. And I think what the main take home from this talk is that not being able to do cath should not equal not being able to offer up some proof of coronary quality. And so getting to that, the burden of coronary proof, I think this recent SRTR study is very illustrative of this issue. So we all know here on the call that DCD heart volumes are growing rapidly, comprising now, I think, a third of donor transplants, heart transplants in the United States. At our shop here at Vanderbilt, 50% actually. So 50% of our heart implants are DCD hearts. And in this really provocative study, so we're talking about 2023, and a total of 4,000 DCD donors age less than 55. In about 80% of those scenarios, the heart was not recovered or used. Only 15% were actually transplanted. And according to the SRTR heart yield model, that for sort of comparable scenarios where we otherwise would have used the heart, we're talking about up to 1,200 DCD hearts that probably were usable. Maybe not all, but that is a huge figure. That's a fourth of the total volume, roughly, of the number of hearts done in the United States. So this is tremendously impactful if we could figure out how to alleviate some of those barriers. And I personally believe that coronary evaluation is probably the biggest gating issue or question in this that underlies this slide right here. I think it's the ultimate bottleneck in many instances. And really, the fact of the matter is, the data is already there in the vast majority of cases, meaning I'm hard-pressed to imagine a scenario where a donor, DBD or DCD, hasn't had at minimum, a non-contrast chest CT. That's almost a given. It'd be unusual, I think, in my experience, to encounter a scenario like that. And it's from this non-contrast chest CT that you can at least obtain some data related to coronary calcification. And with that data alone, and the ability to potentially quantify the amount of coronary calcium, that could in of itself be plenty of information to determine whether that coronary anatomy is suitable for donation. And the proof of that is, and it's also a super important point, we're not talking about a super exotic type of evaluation or scan. You'll see advertisements all over the country at small hospitals where they're talking about get your heart scan, get your calcium score done. And that's basically the underlying technology that we're talking about, is being able to grade the amount of calcium. Thankfully, there's a radiologist here on the call that can keep me honest. But this is kind of like my caveman, dragging, cardiac surgeon's interpretation of the Gatson score. But 0 means no plaque. And basically, when you gate the scan to calcium and you're looking for white specks, because white means bone or calcium, and you look at the coronaries, and where the coronaries are, you don't see any white specks or flecks, that should mean there's really no calcium, and therefore very low risk of some coronary issue. Now, obviously, as we'll get into, it gets a little bit more complicated if it's not totally spec-free, where you have maybe higher scores. But I can't tell you how often here at Vanderbilt we've resorted to using this, sort of just looking at the non-contrast chest CT, seeing if there's any white specks, and if there's none, and with an offer that's otherwise reasonable, that clinching it and being able to do it. And there's even beyond that, the ability to do other scans, which we'll get into, to up the ante, if you will, to kind of, if it's not as clear cut with zero plaque, you could do a more advanced type of scan that most hospitals can still do to get that next level of vetting to sort of assuage any concerns about the suitability of the coronary anatomy. And again, I don't want to waste too much time because I want to leave a lot of time for discussion, but this is something we've studied here at Vanderbilt. We're in the process of submitting this for publication and presented this. But in over 500 patients, we looked at coronary vetting and how it was done and how did it impact the outcomes. And in over half of these cases, all we had was CT scan to do our coronary vetting, which is a lot. And of those 300, 60% were contrast enhanced, but 40%, that's 120 donor hearts that we transplanted and that did fine. We only had the non-contrast chest CT that I just talked about. So that's a huge proportion. And basically, if you look at the donor characteristics, not surprisingly, the donors that were predominantly assessed with CT scan only were mostly DCD. 50% of those were CT only, were DCD donors because cath wasn't an option. And they were higher risk, they were older, had higher risk features such as smoking history or hypertension and diabetes. But importantly, as far as clinical endpoints are concerned, we did not see any significant difference in adverse events such as severe primary graft dysfunction or mortality, even at 1 year. And this, when we actually looked at the data and looked at very small subgroup analyses, which I think we reached some of the limits of statistical analysis, there was really no mortality benefit in that cohort of donors over the age of 40 and older, where CT was really the only way that we were going to do a coronary assessment. There was absolutely no way we were going to get a cath, and there really was no mortality penalty for that in our series. Now, what's missing from this series is long-term CAV data, which we are getting, but at least in the short term, it didn't seem to have a discernible impact on outcomes. And I think this is where we kind of transition to how this looks in practice. And really what it means is a pragmatic CT first adoption pathway for OPOs, where you can link the source data, the raw CT scan data, particularly in these scenarios where cath is not possible. And we can actually standardize how these CT scans are captured and also do the calcium scoring to formalize this analysis. And then, of course, you could pair this information with all the other features in that donor to come up or to arrive at a risk assessment for that particular donor. And this kind of is following the usual path for what triggers this kind of data capture and analysis and how it's summarized and whether or not it merits escalation to a higher level of imaging sophistication, such as a CT, but really just following the trigger of what would normally prompt a concern and desire to pursue a coronary vetting pathway, and starting with this basic non-contrast chest CT and escalating accordingly based on the data that's captured and analyzed. So just in closing for my part, I hope I've shown and I firmly believe that the inability to get a cath in a given donor should not by any means mean that donor heart can't be offered. It certainly can. I think it's leveraging the power of CT scan and some of the analytical possibilities that a Mosaic can enable to really close the loop and determine whether there truly is anything objectively concerning from a coronary anatomy perspective in that particular scenario. And I think here's where we transition, right, Dr. Lee, to Dr. Falk?
Yeah, you bet. Just a little kind kind of introduction to how we got working with 3DR Labs. Um, a number of years ago, many years ago, probably over 5 years ago, we got hit in the middle of the night pretty hard from Stanford Pediatrics. Our support people were telling me we've got a lot of requests from Stanford Pediatrics on getting DICOM files uploaded in the middle of the night, and so we worked out. We said, well, let's work out a way to get files to them directly. But then we started asking them, what are you doing with this? And this is the transplant program. And he said, well, we're actually taking these CTs and we're creating volumetrics for the heart, because currently we're using a proxy, which I call it a proxy, but he was saying currently we're using height and to some degree weight and a certain percentage that, 50% greater than a ratio to size hearts. And he said, everybody knows that that's not really a very valid way of looking at things. And so we're using actual 3D volumetrics to get the actual volume. We're like, that's amazing. But this is something that you're doing when? And they said at the time of offer. And so that started a whole process for us to really dig in and figure out how we could make this available at the OPO stage and provide 3D volumetrics so it could be offered to all the transplant centers. So they weren't trying to do this, and actually almost none of them were doing. Just this was a fairly novel scenario with the pediatric heart program, and we went on a mission to find out a way that we could, because we had all the data. How do we put a system in place where we can do some of this imaging? There's a few different systems out there like Terra Recon and Fuji and some of these others, and make that available in the cloud. Again, this is moving data to a centralized place and applying tools. And that's when we found out about 3DR Labs. And that started a relationship with 3DR Labs back then, and it just got deeper and deeper. And I'll let Dr. Falk, if you can kind of introduce a little bit about 3DR Labs as a founder and how that kind of fit into, the truth is in the imaging, and how can we get this available in a stat scenario in the middle of the night. So go ahead, Dr. Falk.
Sure. Thanks, Lee. Thanks, Dr. Lima. We started 3DR 20 years ago now, and it grew out of, I developed a 3D lab for our hospital system, and we saw tremendous gains in efficiency, in quality, in turnaround time, all those things, and in cost by centralizing all of our advanced visualization. And for those of you who aren't aware, 3D post-processing just means taking CT or MRI data, or really anything, but most of what we do is CT and MRI, and doing things to it, reformatting the images, measuring things in a way that you provide additional clinically useful information. And so it's easy to do that within the four walls of your own institution. The challenge we had was, if we're going to offer this as a commercial laboratory, the same way Quest and LabCorp do for blood, we have to be able to move images across multiple different institutions, and we have to do it quickly, securely, and with high quality. So that was kind of initial 3DR Labs. As we've grown over the years, we've added a kind of a marketplace or a platform for AI algorithms that we can offer to our sites. And most recently, last year, we acquired a company called Strings, which is an agentic AI product that sits in a hospital system, and it monitors, detects, and learns in order to more rapidly address anomalies or to organize workflow in a more efficient fashion. We were actually a customer of Strings, and we liked them so much that we bought them. So that's the background on those. But our core business was the laboratory side, where we get CT and MRI data sent to us, and then our techs do something to those images and then send them back in a ready-to-read state. So it really is a model that fits well in the transplant world, where you have potential donors anywhere in any type or size of institution with varying degrees of locally available sophistication in terms of imaging. And you need to get the data, analyze the data, centralize it, and distribute it to the transplant centers rapidly so that important decisions can be made one way or the other. And we process over 60,000 cases a month, and we operate 24/7. So, it was a good fit for us to kind of slide into that role. And we're really excited about working with CompuMed and working with the transplant centers to try and make this flow as efficiently as possible. Getting back to what Lee was saying and what Dr. Lima was saying, there is a treasure trove of imaging information in hospitals across the country. And when you have a potential donor and you need to know, is it thumbs up, is it thumbs down? Are there things that will rule out using that donor? There's an efficient pathway to get there. And it may be using imaging that is already available in that institution. It may be supplementing that with an additional CT scan that's performed at the time of, decision-making and analysis. It may be a combination of both. And it depends on the acuity, and it depends on the organ, and it depends on the disease process that you're looking for. But all of that, can be done efficiently. And that's what's really interesting about this project for me, is working with CompuMed and working with these centers. How can we do this quickly? How can we do it efficiently? And how can we do it with great accuracy? So a patient may have had a chest CT for a completely different reason a year ago, and that data is sitting on the PACS. Interrogating the report may not be helpful because the calcium level of the coronary arteries, or whether there's calcification on the aortic valve, for example, may not have been explicitly addressed in the report. So it needs to be looked at and analyzed again, but it does not necessarily need to be rescanned. Other things maybe need to be done on a more acute basis closer to the time of decision-making for evaluating for other disease processes. But in terms of coronary disease, it doesn't happen overnight. And so you can go back and see what's in the PACS, see what that patient's had done, and potentially save having to do any rescanning at all in order to answer that question.
And I think, Dr. Falk, that's really where this started a number of years ago with the 3D volumetrics. Of course, CompuMed has very subspecialty doctors, very specific transplant-centric subspecialty doctors, and we've been getting all these images from the OPOs for years now, and have the sharing platform. But this is a way to bring a much higher level of post-processing, the things that 3DR Labs has available to provide these novel ways of getting answers to these questions that the transplant centers really want to know. An example of that, and Dr. Lima, this is from some of our discussion. One of the questions, of course, to answer to one of the modalities is an echo. If they say, I need an echo, well, obviously they need it for more common things like EF. But one of the other reasons that a transplant center has said they want an echo is because they want the aortic root diameter when we've asked them. And so then we ask, well, why do you want aortic root diameter? Well, because I want the aortic root circumference. Oh, why do you want the aortic root circumference? Well, because that's what we're sewing into the recipient. It's like, okay, so you're getting that from the echo, but we can also get structural information from the CT. And so what if we give you the actual, the shape of the heart, the volume of the heart, the vasculature of the aorta? So not just an aortic root diameter that's measured from an echo, but the actual structure to give you a lot more information. And that was something that was never even known it could be asked for, and this is kind of how that has combined where we have the standard interpretive side of those images, but then we have this other ability to get much more robust information to answer those questions. I don't know, Dr. Lima, if you wanted to comment on that at all.
Yeah, and it's just one of many examples where a lot of what's asked for and done routinely as part of the standard diagnostic workup for a donor heart is just, well, this is kind of what they always want, or this is what they always ask for. This is how we've been doing it for 20 years, 30 years. But, times have changed and technology has certainly advanced. And so it begs the question, as Lee mentioned, what is it that you're actually trying to get at? What is it that you actually want to know? And maybe you could be more, leverage the technology and imaging that exists now that's at our disposal to get a more direct answer. Coronary anatomy is one of them. The size and dimensions of the various structures in the heart, what you're sewing into, the vessels, size of the heart itself. That's a whole other discussion. Maybe that's a whole other webinar. But size matching, that's a huge potential there as well to leverage some of this type of technology. So yeah, I think it's just one of several other examples where we're indirectly vetting through kind of what we've always historically believed is what we have to choose from as far as imaging.
Yeah, I would agree with that. And in terms of the calcium score itself, a calcium score of 0 means there's no calcified plaque. It doesn't mean there's no soft plaque. There could still be soft plaque there, but as a statistical risk assessment tool, it's outstanding. I mean, the chances of a significant coronary stenosis with a calcium score of 0 are very, very low. So you can picture kind of a triage tool. Okay, we've got a chest CT that was done last week, and the calcium score is 0. That may be enough. At that point, say, hey, I'll take that heart. What if the calcium score was over 1,000? At that point, you would say, there's no way I'm taking that heart. It's extensive plaque disease. But also as a triage tool for that great middle ground of, the calcium score is somewhere between, 50 and 500. It could be all, superficial, non-obstructive disease. It could be that it's all mature calcified plaque. It could be that some of that plaque is going to be fatty and at risk of rupture. So at that point, that may be a triage tool to move on to the next level, which would be coronary CT angiography, which I would argue in today's world, a well-performed coronary CT angiogram and an echo is getting to be surpassing cardiac cath as a gold standard. You get not only degree of stenosis, but you get plaque morphology and you still get the functional data. And, that may be kind of the ultimate tool for, making the call heads up or, thumbs up or thumbs down on a particular case. So, there's really, it sounds complicated, but we're actually trying to make the complicated decision-making process simple by targeted, smart use of imaging.
Yeah, I think some of the things that people won't want to know on the webinar here are, how do I practically get this? And here, I think it'd be good to go through this. There are some questions actually asking this very thing here. What needs to be done on the scan in order to get the score? And does the scan need to be gated, a cardiac scan? And then are these services typically available? So I think it'd be good to go through the screening methods, and the next slide actually shows some of those these different levels that we're talking about. So I think we should spend a fair bit of time in this area, and certainly for those that are on the call, if you have more specific questions about this as we're talking about it, certainly let us know. But why don't we go through the Agatston score here itself and the difference between that and the coronary CCTA, and then we will, Dr. Lima, you and I can kind of delve more into this calcium screening option too, which is to some degree a rescue pathway, and will allow us to go into the potential donor even if you can't get the DICOM file. So let's talk about the difference first between the Agatston and the coronary CCTA.
All right. You want to take this one, Lee?
Yeah, you betcha.
All right. So the Agassiz calcium score, up until recently, it required a gated CT study without contrast. With some of the newer AI products and analysis products that are out there, you can get extremely accurate calcium scores, up to 98% accuracy with non-gating and with thin sections, say 3 millimeters or less. And generally in the CT world, most facilities archive their images in the 3 to 5 millimeter range. Most people do not archive the raw data, which is 0.6 or 0.5 millimeters. But they're generally in that 3 to 5 millimeter range. And some of the newer programs that are out now can actually take 5 millimeter slice thickness and give you an accurate calcium score.
Well, and then just to clarify on that is actually how that's sent to CompuMed, and we have the pipe directly to you. So just for those on the call, sending to CompuMed is the same as sending to 3DR. We have a direct pipe there.
Right. Yeah, you're not going to have to do anything extra. It's just workflow.
So just again to clarify here, and this has changed even just recently. We had initially started this in 3 millimeter slice or thinner was the requirement for the Agassiz calcium score, and so we were able to do the calcium screening methodology on the 5 millimeter slice. But this has just changed, and so now 5 millimeter slice or less, we can do the Agassiz scoring on that. So, and I think this is really important for the OPO world. A lot of the DICOM files that we get, the chest, abdomen, pelvis, and the chest CTs, those are more often than not are 5 millimeter slice CTs. So this has been even a more recent positive change, that your standard CT that Dr. Lima's talking about, that you're getting almost all day, every day, that we can do the Agassiz calcium score on, and the 5 millimeter slice. If we have the DICOM files, we can do this scoring. And maybe Dr. Lima and Dr. Falk, you guys can talk about a little bit more on the certainty of 0 and the certainty that it's occluded, and then the kind of gray area in the middle, but how this can help on the decision side.
Yeah, I mean, and so we've been in scenarios many times where, because remember, it's important to state this out loud too. There is such a thing as being able to go and assess the donor heart in person and just be sure, because the flip side is also true. We could have had a cath and the whole 9 yards, and just because a coronary angiography is completely clean doesn't mean you go and at the donor and you're supposed to palpate the donor coronary arteries as part of your gross visual assessment of the donor heart, right, in person. And every now and again, you get surprised. There's some calcification or something that was not appreciated on any imaging, but you're there in person and you're able to assess it. So at a minimum, I think some of this, gray zone stuff, there could be enough positive data where, like, okay, the very encouraging findings that there's very little to no calcium on the non-contrast chest CT. That alone could potentially be like, well, let me go check this out in person and see. And if it looks good and the heart looks great, we're taking that heart, right? It's a no-brainer. Now, would I be very, and Dr. Folk has kind of touched on this, it's when you get into the not so obvious scenario, the gray. You obviously, there's the no spec, completely free of calcium, CAC of 0, and then there's the opposite end where there's clearly a big calcified plaque in the main artery, right, which we would never take. But then what about all the other stuff, in the middle? And that's where I think the escalating the level of imaging comes into play, which obviously Dr. Folk is the expert, and I let him speak to.
No, that's it. That's exactly right. And I think for people who are, not intimately familiar with calcium scoring, Just because, when we do a CT scan, we're not looking at the patient. We're looking at pixels created from sending x-rays through the patient. So the Agatston score only scores something with a Hounsfield unit measurement of greater than 130. That's what the Agatston level is. So you can have faintly calcified plaque that doesn't reach the marker of 130 Hounsfield units, and it will have a score of 0, but there will still be calcified plaque there. It's just not calcified enough. It's a risk stratification tool. So a score of 0 still says very, very, very low risk, but it doesn't say there's no plaque there. So, that's kind of the first thing for people to understand. It's a very good risk assessment tool, but it's not actually looking at the anatomy or palpating the anatomy. And then in terms of the coronary CCTA, we are seeing incredible growth in the adoption of CCTA nationwide for evaluating acute as well as chronic chest pain. And so, in terms of availability of that, if you're talking to a hospital, a rural hospital, and it's the middle of the night, you're not going to get a coronary CTA today. Now, in 4 or 5 years, it's becoming a more routine tool by the emergency department doctors to evaluate acute chest pain. And so it's being adopted. The ability to do these tests is getting more and more widespread. So over the next 5 years, we're going to see a lot more hospitals that have the capability of doing a coronary CT angiogram in the middle of the night, which I think will bleed over to help on the transplant side as well when you need something stat. They require things like gating. Sometimes you have to slow the heart rate down a little bit to get a good scan. You use contrast, so there is a contrast load involved in it. But by doing that, you can see percent stenosis, you can see the type of plaque, you can analyze the risk of rupture of that plaque. So you get a lot more anatomic information about what's going on with those coronary arteries. And it should become more available over the next 5 years from more and more hospitals.
So there's a couple of really, I think, important things that are good to underline. Number one, what you mentioned, Dr. Lima, about the visual inspection, and I think that's really key here, because what all of this is trying to not be surprised, not make it so that the transplant centers are not surprised when they come, and they don't have a regret if they don't come. And there are lots of variables. This is unique in transplantation, is that there is ability to do a visual inspection to validate and verify. And this is exactly the thought process that we went through in the volumetrics. There were OPOs would provide CTs, and maybe a transplant center, if they had time, they would do some measurements and they would try and estimate. They might estimate from BMI how big the liver would be, etc. But then they would come and they would actually get to hold it in their hands, but they'd already made the decision to come. So the volumetrics was a way to give accuracy in something that could be validated and verified. So there's a different level of concern about something like that can be verified than if you're identifying cancer and they are taking that with kind of as gospel and then putting it in the recipient. So the ability to actually inspect and inspect the coronaries, that was actually news to me, Dr. Lima, when you talked about that, actually massaging the heart and being able to tell if there's calcium in there. I recall a scenario where we had read an echo, our doctors had read an echo and hadn't identified vegetation, and this heart was turned down because of a vegetation. The OPO brought it to us. Our QA process has it go through immediately through that same doctor and then others, and we couldn't see the vegetation. We got it on a call, and the transplant program had said, yeah, actually, this happens often. And when we take the heart out and we cut the aorta, we look down the aorta, we look and see the valve, and you can visualize that. So there's this ability to validate. What we're trying to do is get more information to be predictive of what they're going to find when they get there. So I think that's really important to know, that this still allows the transplant surgeon the visual inspection allows to be hands-on and to make that determination. And the second thing I think is very interesting for OPOs from the CCTA that the heart cath has been a gold standard, but it seems like Dr. Lima and Dr. Falk, what we're hearing is that the CCTA is really gaining the ability to replace, in a lot of cases, things that you would see in the heart cath, and we know it gives even more information on the structure side of things. So, interesting enough, if we were talking to OPOs now for their DCU, if they're setting up a DCU and they're trying to make a decision on a cath lab, do you do a cath lab anymore, or do you put your investment into the CT technology? And then when you want to do CCTAs, there's a fairly good software component, but that can be added on, and you're not needing to have a cath lab that you use very little. You can be putting your money into the CT equipment, which there's a whole bunch of other things that we can do with the CT equipment as far as imaging on the organs. So, do you guys can you comment on those two areas?
Yeah, no, I think that's exactly right, and I think what you're saying, the All-Star game was on last night for baseball. To use a baseball analogy, I think what we're saying is that there's a way, you're not trying to bat 1,000, but you're trying to use imaging to significantly increase your batting average. And I think that's a good way to look at it, and gain efficiency every way you can. And I think that there's an ability to do that with advanced imaging, certainly on the cardiac side and as well as on the abdominal side.
I love that analogy. So, yeah, I mean, I think the other great visual that Lee had presented earlier, that funnel diagram, I think it's moving the needle closer to lower on that funnel, because I think we're missing there's a very sizable subset of patients that don't even make it, much down the funnel. They're sort of X'd out really early on because, they're going to want a cath. We can't get a cath on this donor. Done. End of story. But you kind of forego the opportunity maybe to just leverage the imaging you already have, or maybe just kick it up a notch and do a different form of non-invasive imaging to get to your answer, and maybe have another donor that you could use to save lives. So I love that analogy of increasing the batting average. I agree with it 100%.
So maybe we could talk about the calcium screening. So as far as decision matrix, what we have is the Agassiz score is available stat. It's with technology that uses imaging that most OPOs already have. So if you're uploading your CT to CompuMed, you can ask for the Agassiz calcium score, and that's for a donor. Well, what about potential donors? Now, potential donors, of course, there's somewhere in the order of 100 to 1 potential donors to actual donors. So a lot of volume there. This calcium screening is an opportunity that with Mosaic, we can actually do a screencast with the hospital. We have to get set up with you with Mosaic, but we can do a screencast to the hospital if you have a CT in the hospital. And we can teach you as a coordinator to put it in bone Hounsfield and hit the cine loop in for the images of the heart. We can actually capture that video recording from the screencast even without getting the CT out of the hospital, and we can do a calcium screening on that. And Dr. Lima, if you can just talk about that example, even what we did with Connect Life. That screening and how you would evaluate that.
Yeah, so it's basically yet another workaround, right? You are basically leveraging technology to use what's available, and it may be just that you have to configure how you're viewing that image at that particular hospital and just capture it by video, and then you could then derive a calculation for the calcium. And again, I guess it boils down to how much of the white specks are there. But again, if there's literally none, right? There you have it. I mean, that's a compelling argument that donor heart is potentially viable, right? Absent other issues, but as far as coronaries are concerned, maybe not so much of a big deal in that case. So that's, I think, very, very valuable approach. And I think with that, you basically rarely would have a scenario where you couldn't derive some degree of calcium vetting on the coronaries. Almost a never situation.
So from a triage perspective, if we have a 5 millimeter slice CT with no contrast that has imaging of the heart, doesn't have to be gated. Gated, by the way, for those that don't know, means that you have ECG electrodes on there, and the CT machine knows when the heart's beating, so it reduces the artifact. But a lot of the new AI models, as we've just been hearing, now we can go to 5 millimeter slice, and they don't need to have gating. So this technology is advanced in a way where pretty much a standard CT that you have right now will give much better visibility into the coronaries. And for potential donors, if you can't get a CT, we have a rescue pathway. We need to work with you slightly on how to set that up and how to teach your staff to change Hounsfield in the PACS. But it is a rescue pathway. And if we capture those images just in a video, and Mosaic has the ability to do that, then we can give that information. We can use that information to do a calcium screening. And on either end, you have a pretty good degree of certainty. If there's no calcium, no white flecks, or in the scenario when there's a lot, then it allows you to move on without a regret. So that's a huge opportunity for potential donors. And if we can do the Agatston score, then of course that's a more standard process. One of the things that has been asked a lot, and that is, okay, this is great, but how do we get transplant centers to accept? How does this change what they do? And I think, Dr. Lima, if you could address some of that in how you guys made the decisions and what you would say to transplant centers specifically, if we can get an Agatston score, and how that can change how they make decisions.
Sure. Well, first and foremost, it's a very, very small world. We all work in this transplant space, heart transplant space. All the surgeons know each other. All the cardiologists know each other. So I'd be happy to talk to anybody about it if that scenario came up. And because at the end of the day, it's like a curbside, and you're trying to see if you could help someone use a vital heart to save someone's life. So it's not
and not to interrupt, but to interrupt just so people know, that is an official product available through CompuMed, so that it's set up so that if there is a requirement, if there's a transplant center that wants to talk to another transplant center, someone who's using this, we actually have that methodology available so that you can talk to Dr. Lima and the likes of, colleagues of his, so that they can actually talk to the transplant center. So this is a really important aspect, I think, of the next, months in the next year or so that people will have someone that they can actually talk to that basically is saying, right, Dr. Lima, if you don't take it, I will.
Well, 100%. And then selfishly, I think if it's a pretty good-looking heart, and we'll take it. I mean, honestly, that's no exaggeration. Or at least want to know more and learn more and see, okay, so far so good. I'm not saying no. Could we get maybe the next level of imaging, knowing that we can't get the cath? But from what I'm seeing so far, this still looks pretty good. It's promising.
And on that regard, I would just say to OPOs that might be on the call, transplant centers, all of you, if obviously we have this set up so we can do it at the time that it happens, but it would be certainly nice if it's something that if people want to set something up and have a discussion ahead of time, that would be great. We can go over a lot more data, etc. So in the middle of the night, if you have a calcium score that you need, we can do it. And if that comes back in such a fashion that it shows that it's good, and then there's some pushback from the transplant center, there's a rescue pathway so that if they want to talk to people that are using it, they can get that. We can get that done as well. If there's a way that we can do this ahead of time, and if you've got certain centers that you'd like to preload this, if you will, this discussion, we're happy to do that as well.
Yeah. And we also have a couple recent cases that we're going to review with OPO and with Dr. Lima and see if we could have done something differently. One comes to mind is the Gift of Hope one we just did. There's another question in here too. I just
good.
Wait out. Sorry.
Would a very low Agassiz score, would there be a possibility of expanding donor potential by older age donors?
Absolutely. That's and I think that basically is the crux of it, right? It's usually the older donors where historically we would say, yeah, we need to vet the coronaries, and often in brain dead, it's okay. There's little barriers often to get a cath. Sometimes there is, you'd be surprised, but it's really in the DCD realm where the opportunity is massive, because typically 40 and over, most programs, they're going to want to vet the coronaries. So if it's a DCD, it might be difficult to pull off. But there's a lot of DCDs that are 40 and over. And then if you start talking about those that are maybe less than 40 but have positive tox screen for cocaine, and they're a lot of pack histories in smoking, or using other illicit drugs, whatever it is, that would raise the alarm to say, hey, I really need to see what those coronaries look like. This would definitely move the needle on that. But also, yes, definitely older donors. And that's kind of where it's come into play for us, is older donors, for sure.
Well, and I think that's kind of one of the interesting things. If you look at the donor funnel, I think it was Region 5 showed it with actual numbers. And the conversations that happen, it's somewhere under 20% of the brain death donors that are ventilated that are offered. Only 20% of them get a conversation. 80% don't get a conversation. Now, some of those, of course, are obvious rollouts. But when there's a lot of proxies, when somebody's, like you say, old, a lot of pack years, maybe morbidly obese, all sorts of things, these are just stacking on top of each other as far as proxies to say, this is high risk. And if you can't get some of these things like a heart cath, then you've got to triage. But there's been lots of scenarios where the proxy, the indication, when you look and delve deep, it's actually not the way it is. It just appears like there's a plethora of heart offers that are not even being made. And honestly, when we were at AOPO, I think there were people that were almost a little bit upset. It's like, man, I'm going after every organ, and you're telling me somehow that there might be 500 hearts out of 4,500 hearts that we've recovered? That's like 20%. How could that be? And that's really what may be going on here. This is a mission I think we need to do together, all of us, because these are some substantial benefits and changes to saving lives. It's just changing some of the ways that have always been done. And it doesn't mean that those are bad ways of doing it. It's just that there's new opportunities now available. So, and there's lots more like this too. It's not just coronaries. We're doing similar on steatosis of the liver, and glomerular density for kidneys. And there's all sorts of things that when you dig into what they really want to know, there's so many ways that imaging can get more to the truth. And Dr. Falk, we've got many opportunities here, don't we?
Got a lot of work ahead of us.
Yeah. Very good. Well, thanks very much for joining.
Thank you,
Thanks, everybody.